Okay, on to the next module here with this man either sneezing or blowing his nose. So we're going to talk about rhinitis, which is inflammation of the nose. We're going to talk about asthma and COPD. So we're gonna be in the upper respiratory tract for a while with rhinitis, and then go to the lower respiratory tract with asthma and COPD. So I know that you're also reading ATI book, but I'm just going to discuss asthma and other pulmonary disorders um, without looking at the ATI book. Uh, the ATI book you can easily read, but I'll just tell you the since I've been working for 30 years, just what is asthma, what is COPD, what's the difference, what should I know about them? So asthma is always made up of two underlying issues or problems. There's bronchoconstriction, so there's irritable airways in the bronchial tubes. So bronchoconstriction, and there's mucus production and inflammation. Okay? So if you remember that asthma always consists of bronchoconstriction and inflammation, you will totally understand the treatments that we use for it, because invariably the treatments address one of those two problems. The bronchoconstriction from the smooth muscle contracting from irritable airways, or from the tremendous amount of inflammation that occurs with asthma within the airways and makes it difficult for people to exhale. So, so asthma is a condition with difficulty exhaling air. They can breathe in the air, but because the bronchial tubes are even more narrowed with exhalation, they have difficulty exhaling the air. Okay? So just remember these two conditions, bronchoconstriction and inflammation. In a normal airway, such as the above picture here, is wide open. There's a mucous membrane or epithelium. There's no mucus in the airways. The smooth muscles aren't contracting down and tightening the bronchial tubes. So asthma is typically felt to be a genetic disorder and environmental components. It tends to run through families, but there's definitely an environmental component to it as well. So the allergic component to asthma is seen by people who have asthma often have allergic skin reactions such as eczema. They often have nasal polyps, um, and they're from allergies as well. So we think there's a mixture of a genetic component and also environmental. And so when I see someone with asthma, I often ask them, do you have eczema? Have you ever been told that you have nasal polyps as well? So think of it as genetic and environmental. So I won't mention much on this slide since it looks like there's just links to asthma treatment and YouTube. But remember, asthma patient teaching really comes down to understanding the disease, knowing what their triggers are, because people often have triggers to their asthma, making sure that they're not smoking. Smoking can definitely trigger all the toxins in smoking can trigger asthmatic attacks, and also making sure that they're very compliant with their medications, whether it's inhalers, which typically asthmatics are on, or whether it's oral medication that sometimes asthmatics need. Okay. So there's a huge variety of inhalers, and we're gonna talk about the different inhalers. And just try to keep in mind that there's two components of this condition called asthma. There's the bronchoconstriction, and I'm going to have inhalers to address the bronchoconstriction so I can bronchodilate. And there's the inflammation and mucus production, and I'm going to have inhalers to reduce mucus production and secretion. And often they're used in combination to control someone's asthma. Okay? Children often come in, and one of the first symptoms of asthma is just an ongoing chronic cough. They just have this hacky cough at night, night after night after night. Or, for example, when they get a mild viral infection, they're wheezing. And every time they get a cold, they wheeze. But remember, asthma is a recurrent condition where you have recurrent airway bronchoconstriction and airway inflammation. It's not like you get it once and you had some wheezing with one cold and now you're called an asthmatic. It's a recurrent disease that has flare-ups, okay? And we call them asthma flare-ups. So we don't diagnose asthma based on one episode of wheezing, coughing, and the requirement to use inhalers to settle it. It's recurrent. So because a lot of the treatment for asthma comes in the form of inhalers, the medication needs to get deposited within the bronchial tubes. It takes a lot of skill without an aero chamber or a spacer. So you have to shake that little canister, you have to put it to your mouth, you have to time when you press the canister and then take a big breath in. So it can be very difficult to get skilled at using an inhaler without a spacer or an aero chamber. So especially in children, but adults as well. When we look at how people take their inhalers, they're often not taking them properly, meaning there's less medication being deposited within the lung. So aero chambers and spacers eliminate the need to time the puffer and your inhalation at the same time, because the medication gets misted into that chamber, and then with your mouth on the other end, you're taking 2 or 3 deep breaths to get the medication into the lungs. So spacers are very popular. So nebulizers. So inhalers are basically canisters that are filled with the medication for you. Some inhalers you take as needed, such as albuterol. You know, you're feeling short of breath, you're wheezy with your asthma, you can take albuterol inhalers. Some inhalers you take regularly to control your asthma, and we'll get into that on some further slides. So some people, the inhalers just doesn't get the medication enough into the lungs, whether they have asthma or what's called chronic obstructive pulmonary disease, COPD, and we'll talk about COPD. So nebulizers can be used, and you can get home nebulizers, and nebulizers are used very commonly in hospitals and emergency rooms to really get the medication into the lungs. So the nebulizer, you can see the image there. It just has a mouthpiece that you hold to your mouth, and then there's a little cup that we pour the medication into. So whether it's albuterol or ipratropium, which is one we'll talk about, and we turn on the compressor, and it mists the medication, and people take inhalations while it's misting. It typically mists for approximately 5 minutes, and it really gets the medication deep into the bronchial tubes. So that's a nebulizer, and people have these at home as well when they find that they're not able to get enough medication in with their inhalers. So they can be very useful for certain groups of people. Okay, so this is going to be a longer discussion slide. So I've purposely not made the slides above it very long, but this one is basically the treatment of asthma and the stepwise approach that we take. So let's go through this one a bit slower so that there's some understanding. So we'll start at the bottom. So intermittent asthma. So someone comes in and says, listen, I just get short of breath and wheezy 4 times a year. I don't need to take, I really don't want to take an inhaler every day to control it. It's very infrequently, and most of the time I don't have symptoms. Or another one is someone comes in, another example would be someone who comes in and says, I just get a bit of asthma and wheezing when I exercise. And other than that, I'm totally fine. So in that case, we would use just a beta-2 agonist. Albuterol is a perfect example. Or there's one called salbutamol. But albuterol seems more common. So and so it's a short-acting, so it's a SABA, a short-acting beta agonist. It's a rescue medication. So you're wheezing, and you take it PRN, which means as needed, right? You have it in your pocket. You take the inhaler out, and you take 1 or 2 puffs when either you know you're going to exercise because you have exercise-induced asthma, or that 3 or 4 times a year where you get wheezy and you take your short-acting beta agonist. Anything after that, we're using control medications because you're getting your asthma more frequently. And what we consider frequent is really anything that is impacting your daily activities, or it's happening monthly even. We need to control it, and you can't just keep on taking beta-2 agonists every time you're wheezy through the day, all day. That means your asthma is poorly controlled. So if somebody comes in and says, I'm having to take my albuterol inhaler 4, 5, 6 times a day, that's not well-controlled asthma. Okay, and remember the 2 components of asthma: the bronchoconstriction and the mucus production and inflammation. So all albuterol does, the short-acting beta-2 agonist, is it bronchodilates. So it's basically a quick fix. This group is the rescue inhaler medication group. Let's go to step 2. So now this is someone who has wheezing on and off every month or every 2 months. They're having to use their Ventolin or their albuterol inhaler quite frequently. And they come in for refills of their albuterol, and we realize that this has become more of a frequent event, the use of the albuterol inhaler, or we notice that they're using, say, 1 inhaler per month, something that tips us off to say this is not controlled asthma. So that's when we'll use an inhaled corticosteroid, such as fluticasone. Fluticasone is a very popular inhaled corticosteroid, and we'll often try them on a lower dose. And so what's fluticasone doing? What's the steroid of fluticasone doing? It's controlling the inflammation and mucus production. And this is an inhaled. So any inhaled corticosteroid doesn't have to be fluticasone. It could be betamethasone. There's a number of inhaled corticosteroids. The most popular one on the market right now is fluticasone, because very little of it is absorbed into the systemic circulation. So it doesn't have much of an effect on the systemic circulation of children or adults. And they take, the fluticasone you take regularly now, whether you're feeling well or not, whether you're wheezing or not. It's a daily dose to control the asthma, because a dose of fluticasone or an inhaled corticosteroid, a dose today typically takes about 5 to 7 days to take its effect. So if you start to miss doses of your inhaled corticosteroid, it won't be very effective. Okay? And on top of that, they have the short-acting beta agonist in their pocket, that if they become wheezy, they can still use their rescue medication while they use their inhaled corticosteroid regularly. There are some alternatives to inhaled corticosteroids. They're definitely not as effective anymore. We used them decades ago. They still exist, and we'll talk about them a bit, they're nowhere as effective as inhaled corticosteroids. So there's two there, cromolyn and nidocromil. Those are inhalers, and they're what are called mast cell stabilizers. So if you recall, a mast cell are cells in your immune system that release histamine, and they can cause bronchoconstriction. These drugs try to stabilize the mast cells and stop them from releasing histamine. Okay, so that's cromolyn inhaler and nidocromil inhalers. Okay, try and stop the histamine release from irritating the airway and the bronchial tubes. Not as effective. They've essentially become replaced by inhaled corticosteroids. Leukotriene receptor antagonists. So the one in this group is called montelukast. So what does this do? This tries to block leukotrienes from getting to their receptors in the airways. This comes as a pill. And initially when it came out, it was felt that it was going to be very effective for asthma. It ended up not really being that effective. And because the immune system and the inflammatory system is very involved in asthma, that's why we use inhaled corticosteroids to reduce the inflammation in the lungs. It was felt that leukotriene receptor antagonists, because leukotrienes are heavily involved in the inflammatory system, would be very effective. They ended up not being very effective. So they are used in the occasional person, but not regularly. And lastly, theophylline, which we will definitely talk about. It's an old drug. It comes in an IV form and an oral form. It's a coffee derivative. So if you can think of all the side effects that coffee does to you, you will know the side effects of theophylline. And it's a mild bronchodilator. Okay, so it had a bit of, just like coffee is a mild bronchodilator, so is theophylline. It's a caffeine derivative. So if you have too much caffeine or theophylline, you're going to be agitated, nervous, tachycardic. You're going to have all the effects of almost like a sympathetic surge. You can get some hypertension. So not a popular drug, and it has a very narrow therapeutic window, meaning the dose that's effective for asthma is very close to the toxic dose. Very narrow therapeutic window. So used much less frequently now. Almost not used, really. We'll still need to know a bit about it, though. Okay, so let's climb the ladder a bit more. So a person comes back, they're on inhaled corticosteroids, they come back and say that they're still having to use their albuterol inhaler, they're still wheezy, they're definitely compliant with their inhaled corticosteroids, maybe cromolyn or montelukast, which is that leukotriene receptor antagonist, was added. Still not very well controlled. Let's go to step 3. So we can increase the dose of the inhaled corticosteroid to a stronger dose to try and control the inflammation, or we can add what's called a long-acting beta agonist, a LABA. So a long-acting beta agonist is a inhaler that you could take a puff in the morning, puff in the evening, and the beta agonist effect lasts all day to try and bronchodilate. So now you can see you have this inhaled corticosteroid for the mucus production and inflammation, and you have a long-acting beta agonist to try and bronchodilate the lungs, the bronchial tubes all day. Okay? And you still have your short-acting beta agonist in your pocket in case you get wheezy. So remember, long-acting beta agonists you don't pull out of your pocket just when you feel wheezy and take a dose. It's for long-term control. It's not for the quick fix like a short-acting beta agonist, which is the rescue group. What else? You can still add you could still add montelukast and try it. You could still try theophylline. Again, you probably wouldn't do that currently. They're still available and out there. But let's move on to step 4. So now the person comes back. We've added a LABA, a long-acting beta agonist, to try and keep them bronchodilated all day, and they're on an inhaled corticosteroid. And they come back and they say, "There's still not a lot of great control." Well, we're going to go higher on the inhaled corticosteroid because we know that's the most effective inhaler for control of asthma. We'll keep them on the long-acting beta agonist, and we could consider adding one of the other medications again. So notice all we're really doing is going up higher and higher on the dose of the inhaled corticosteroid, and of course adding the long-acting beta agonist. And that's what step 5 is doing too. We're going to a high dose inhaled corticosteroid and still the long-acting beta agonist. And you would definitely always have your short-acting beta agonist, albuterol, with you. So, I mean, at this point, we've exhausted. The person's on high-dose inhaled corticosteroids. They're on long-acting beta agonists. What else can we do when they come in still wheezing, still short of breath? Well, we'll offer a course of oral corticosteroids, and it's typically prednisone that we use. It could be another corticosteroid, dexamethasone we sometimes use, and the oral steroid is meant to really address the inflammation and mucus production in the lungs from asthma. We try not to keep people on oral corticosteroids very long because of all the systemic side effects of oral corticosteroids. And there's many of them. I'll just mention some. There's hypertension, there's skin thinning, there's bruising, there's hyperglycemia, there's cataract formation. The list, there's weight gain, increased hunger, gastrointestinal ulcers. There's so many side effects of long-term use of oral corticosteroids. that we try really hard not to keep people on them long term. Short term is fine. And finally, at step 6, this is usually by the time they've been referred to a respiratory clinic. There's a monoclonal antibody that decreases the allergic response. So it's a monoclonal antibody that's targeted towards the allergic response, which we think is responsible for the ongoing allergy in some people, and it tries to shut down the allergic response, and that's omalizumab. So remember, MAB, monoclonal antibody. This one's used for asthma. Not many people would have to get to this step. Usually by an earlier step, the asthma has been controlled. Okay, so I hope that helps make some sense. Remember, the mainstay treatment of asthma control is inhaled corticosteroids. The rescue medication, only short-acting beta agonists, beta-2 agonists, like albuterol. And there's long-acting beta-2 agonists that are for long-term daily control. Okay, you take a puff in the morning, you take a puff at night. It's not meant to rescue you. So let's talk about albuterol inhaler. Very common inhaler. It's your rescue inhaler. So short-acting beta agonists are your rescue inhalers only. And typically, when you're on, say, for example, an inhaled corticosteroid, you would take the short-acting beta agonist first, and it bronchodilates the airways, and then it allows the inhaled corticosteroid to get deposited further down in the bronchial tubes. So albuterol, salbutamol, terbutaline, those are short-acting beta agonists. They're all like albuterol. Long-acting beta agonists, they end in terol. So formoterol, salmeterol. I know they're similar, but just know the ending. These are long-acting beta agonists. They're for ongoing daily control. You take them in the morning and the night, no matter how you're feeling. Okay, so long-term control, just like inhaled corticosteroids. Okay, so back to albuterol. Indications, it's bronchospasm and bronchoconstriction. So that would be for asthma. That could be for someone with exercise-induced asthma. Every time I go for a run, I get wheezy. Okay, let's use albuterol. Or someone with chronic obstructive pulmonary disease, where they also get wheezy from the damaged bronchial tubes and the mucus within the bronchial tubes. So we can use albuterol with them as well. And how do they work? Well, autonomic nervous system coming back. They're beta-2 receptor agonists. So will they also have other effects on the sympathetic system? They'll have most of their effect on the beta-2 receptors, but they'll still stimulate the beta-1 a bit and cause you to be a bit tachycardic as a side effect, cause you maybe to have some palpitations, some nervousness, tremors. So think of all the things that the other receptors, so okay, well, throat irritation could come with any inhaler. If you took enough of albuterol, it could increase your blood pressure because it's a sympathomimetic. Its most popular receptor to go to is beta-2, but still it'll have effects on other sympathetic receptors. It can cause you to have some insomnia because the sympathetic system is a stimulating system. It can cause you to have dry mouth because the secretions are reduced in the setting of a sympathomimetic. Okay? Contraindications. So certain tachyarrhythmias, so if you come in and your heart rate's 120 or 130, we need to find out why you're going that fast before we give you albuterol, because it'll make it go faster. And people with severe coronary artery disease that are very prone to developing angina, well, albuterol is going to make their heart work a bit harder because it's going to make it beat faster. So they might get aggravation of their angina from an albuterol inhaler. Now, under nursing responsibilities and advice, client teaching, teaching the client not to use aspirin or NSAIDs if you're asthmatic. There's an interaction of asthma with ASA and NSAIDs. People are advised not to take these medications with asthma. Beta blockers. Well, non-selective beta blockers will block those beta 2 receptors, so they can aggravate asthma. Avoiding triggers in your environment. Most asthmatics know what triggers their asthma, whether it's pollution, whether it's certain animals, whether it's some kind of perfume or scent or deodorant. Something usually triggers their asthma, or it can be a food. Teaching drug administration techniques, that really comes down to getting very comfortable with the inhalers and knowing how to take them properly and being very compliant with them. The bronchodilators, that would be the short-acting bronchodilators. Albuterol is typically used prior to an inhaled corticosteroid to bronchodilate and allow the second inhaler medication, such as fluticasone, to get further into the bronchial tubes. Okay, so we're going to go off the topic of asthma, which often begins in childhood, by the way, and then continues on into adulthood. You can develop adult asthma. Often it starts in childhood. And we're going to talk about COPD, chronic obstructive pulmonary disease. And COPD is a mixture of two conditions together. So just like asthma had bronchoconstriction and bronchial edema and inflammation, COPD is a mixture of chronic damage to the bronchial tubes, so chronic bronchitis, and emphysema, which is damage and scarring and destruction of the alveoli, which is where oxygenation takes place. So someone who has COPD usually has a combination of these. Some people might have more emphysema than chronic bronchitis, and the other way around as well, more chronic bronchitis than emphysema, but it's a combination of these. So if you ever see a question, or if you ever see someone with COPD, they have some combination of both of these conditions together. And the chronic bronchitis portion, typically it's someone, so typically for both of these it's a smoker, about 90% of people. It's typically someone who has been coughing for at least 3 months to define them as someone with chronic bronchitis. So it's increased sputum production and increased coughing for 3 months or longer. So what are some of the signs that we'll go into briefly here? So definitely they have this hacky cough. They have wheezing, if you were to listen to their chest. They may have what are called rhonchi. I would look up that term in the interest of time. They can have peripheral edema, so they have swelling in their legs, and I'll explain that in a minute. Elevated hemoglobin. So why would they have elevated hemoglobin levels? Well, cigarettes have a lot of carbon monoxide in them. Carbon monoxide preferentially attaches to hemoglobin and removes oxygen. So the body is sensing that it is hypoxic because it has less oxygen attached to hemoglobin. So what does it do? It produces more hemoglobin. Just like you were to go to a high altitude at the top of a mountain, your body would produce more hemoglobin because it's sensing that you're getting less oxygen from the thin air. Okay, so elevated hemoglobin in COPDers is very common. Overweight, I'm not sure what to think of that. You don't have to be overweight to have COPD or chronic bronchitis. Cyanotic is referring to the fact that at some point you're just not exchanging enough oxygen across the alveoli, and you have deoxygenated blood in your system. So you're hypoxic. You have hypoxemia, and so you look cyanotic. Emphysema, which is the other part of COPD, is permanent damage to the alveoli. And this particular part of COPD can give you severe shortness of breath because you're not exchanging oxygen or clearing CO2. You can have very quiet lungs because there's very little air going in and out. The alveoli have been destroyed, so you don't have that nice sound of air flowing in and out of the chest. The lungs often look hyperinflated on chest x-ray. So they almost just look like hyperinflated balloons because in COPD your lungs can't fully relax back down to a normal size. So what happens is when they're hyperinflated because the recoil of the lungs isn't there any longer. Okay, so just remember, and we'll go over this again for sure, but just remember when we're dealing with COPD, it's the combination of these two. Okay. Now, why the peripheral edema? Because your lungs are damaged, all the little capillaries that go to your lungs, so they start at the right ventricle, goes to the pulmonary artery, and they become capillaries all through the lungs. Well, they're also destroyed in emphysema because they were all around the alveoli. And when they're scarred and destroyed, it puts increased pressure in the pulmonary artery because the blood can't flow forward. And that puts strain on the right ventricle. And when you put strain on the right ventricle because the blood can't move forward through the pulmonary capillaries, you get right ventricular failure, and then you get backup of fluid into the venous circulation, and you get peripheral edema, in particular in your legs. So you'll see we'll talk about a lot of medications and inhalers that have some similarities to the asthma medications. But there's definitely differences between this. And this is a chronic disease. COPD is a chronic disease. And when you have COPD, it's not a friendly disease. If you continue to smoke, the descent of your health goes down very quickly. Okay? So COPD, congestive heart failure, these are serious chronic conditions, and they can often have less of a life expectancy than certain cancers. So it's not a good diagnosis to have, especially if you continue to smoke. So how do we diagnose COPD, whether it's chronic bronchitis, which is damage to the bronchial tubes, or emphysema, damage to the alveoli, that combination? In clinical practice, we don't try to distinguish someone who has chronic bronchitis from emphysema. The whole thing is COPD. And we diagnose COPD with pulmonary function tests. So we do breathing tests. They breathe into a machine, And the machine tells us all about the strength of their lungs and their lung volumes. And we'll get into that a bit later. And you may end up doing it in pathophysiology too. But that's how we diagnose someone with either asthma or COPD. And again, the issue with COPD is it's a difficulty exhaling air. You have so much mucus and scarring in the bronchial tubes that when you exhale, it's difficult to get all that air out. And that's partly why your lungs are hyperinflated. Okay? Okay, so let's do the next inhaler here called ipratropium. The brand name is Atrovent. And ipratropium is an anticholinergic inhaler or drug. So what will that do for the bronchial tubes since we use it as an inhaler and a nasal spray? But let's concentrate on the lung inhaler part. So anticholinergic, well, if you're blocking the parasympathetic system, because this is an anticholinergic drug, that will bronchodilate the bronchial tubes. So that can be useful in conditions where you have bronchospasm or tighter airways, right? Help to bronchodilate them. So there's a couple of other ones. So ipratropium is the prototype because it's been around the longest. There's a new, and it was given, we used it 4 times a day. So you needed to take 2 to 3 inhalations 4 times a day. Tiotropium, same thing, anticholinergic inhaler. It's also called Spiriva. That's only given once a day. So a lot of healthcare providers switched to tiotropium because it's only given once a day. And there's a combination one that has some albuterol and ipratropium in one inhaler, and that is called Combivent. So let's talk about ipratropium a bit. So used for bronchospasm. In particular, it's first line for COPD. We know that albuterol is your rescue inhaler for asthma or COPD. You can use albuterol in COPD, but people take ipratropium daily, regularly for their COPD, okay, as the bronchodilator. It's also used as a nasal spray. It comes as a small nasal spray for rhinorrhea, which is just a runny, drippy nose. And because it's an anticholinergic, it reduces secretions in the nose. So people that get a runny nose, a runny, drippy nose in the winter time, and it just bothers them, they're constantly using Kleenex, will use ipratropium nasal spray because it really dries up the nasal secretions. But also, because it's an anticholinergic, it'll help bronchodilate the bronchial tubes. So anticholinergic, you'll see these terms a lot, so start to get used to them. Blocks cholinergic receptors, another way of saying it, and reduces secretions. So what effects are you going to have if you're taking lots of ipratropium? So say, for example, you decide to take it 4 times a day, which is how it's described or prescribed. But what adverse effects could you get from this? Well, it'll block the parasympathetic system, so you could get a bit of a dry mouth. You'll get some tachycardia because the sympathetic system will override the parasympathetic system that's being blocked. And you could get some constipation. This isn't that common, any of these, except for the dry mouth, because not a lot of it goes into the bloodstream. But think of anticholinergic side effects, and you'll have your answer to what side effects this can cause. Contraindications. Well, anticholinergics are always contraindicated in acute glaucoma because they'll cause dilation of the eye, and that could bring on an episode of acute angle closure glaucoma. bowel or bladder obstructions. So a lazy bladder is very reliant on the parasympathetic system to contract. So if we block the parasympathetic system with an anticholinergic, that could aggravate someone's ability to urinate. And in the same with the bowel, if you have a very lazy bowel or if you're very prone to constipation, ipratropium could make it worse because it's going to reduce the parasympathetic stimulation to the bowel. Knowing the difference between rescue medications and long-acting inhalers is really important. So this one, it's always a good idea to rinse your mouth after using it, but it's not going to be as important to rinse your mouth compared to steroid inhalers that we're going to start discussing. So rinsing your mouth is a good idea for any inhaler, but in particular, the one that you really should remember is rinsing your mouth after a corticosteroid inhaler. And we'll discuss that. Pulmonary function tests. Pulmonary function tests are done before you take the inhaler and after you take inhalers to see the difference, to see how your lungs have improved with the inhaler that's being tested. And of course, because ipratropium bronchodilates, you would take it before taking a steroid inhaler to help it deposit even deeper into the lung. Okay, so remember though, rescue medication for asthma, beta-2 agonists. Rescue medication for COPD, it's still beta-2 agonists. The patient could still take their ipratropium, but beta-2 agonist is the group for rescue medications. Okay, so now let's look at some steroid inhalers. And the prototype, it's one of the older ones, still used, beclomethasone. But you'll see under similar, fluticasone, which is Flovent, budesonide, mometasone, they can all be used as inhalers, as steroid inhalers. So just remember the concept steroid inhaler, as opposed to trying to memorize every type of steroid inhaler. They all do the same thing. The only one here that's an oral medication is prednisone. Okay, the other ones are inhalers. And if you remember the staircase of increasing treatment for asthma flares, prednisone was pretty far up there. We try inhalers first, and we optimize inhalers, and then sometimes we have to use prednisone for a flare-up of asthma, and we do that for COPD as well. But let's go to the inhalers now. So what's the indication for a steroid inhaler? Well, it's for maintenance medication. It's for prevention of flare-ups of asthma. Okay, so you take it every day and you take it regularly without missing doses, because it's not meant to help with your symptom today. It's meant to prevent flare-ups of asthma. So it's a daily use medication. It's not an intermittent use medication. We also have nasal sprays that are steroid sprays, and they're used for all kinds of allergic nose conditions. So for example, in the spring or the fall, where people have itchy, runny noses that are blocked from allergies, many people will start a steroid nasal spray. For example, fluticasone comes as a nasal spray called Flonase. So, and there's many others, Becanase, which is beclomethasone, but in a nasal spray. And you would take that every day to control your allergic symptoms. Okay? And what do these inhalers do for the lungs? They reduce the inflammation and they down-regulate the immune system which is causing all the mucus and the inflammatory response in the lungs. So what are the side effects of these inhalers? Well, you can get thrush in your mouth, those white patchy spots from candidiasis. You can get some hoarseness because sometimes the steroid component can irritate the back of your throat and your larynx. Dry mouth, get weird taste. That's not a big issue. Thrush is the biggest one here, or throat irritation. Mask signs of infection in the body. That would be pretty unusual because most of the time these don't get into the bloodstream. I guess theoretically, if the steroids from these inhalers got into the bloodstream, they could mask an infection. Steroid sprays or inhalers, could they cause hyperglycemia if they get into the circulation? They could, because if you remember, steroids, systemic steroids increase your blood sugar, so there is a possibility there. And growth delays. Steroids slow down growth in children, and that was a concern with many of these inhalers at the beginning. Most studies have shown that it's really not a big concern at all. So I would say the big ones here are thrush in your throat, dry mouth, and if it got into the bloodstream, sure, there would be a risk of masking the signs of infection, maybe some hyperglycemia, and growth delay in children has really been dismissed. Contraindications, active infection. So if you had an active throat infection, for example, it wouldn't be a good idea to spray or to give a flow vent inhaler until the infection's gone, or a steroid inhaler, sorry. So nursing responsibilities, so monitoring mucous membranes, the throat, for yeast infections, which will be the candidiasis. Definitely advising people to rinse their mouth after these inhalers. And why do we do that? Because some of the steroid spray or inhaler deposits on your tongue and the back of your throat. And because it's a steroid, it immunosuppresses locally the tissue, and that's why people get thrush, because they're not rinsing their throat, their mouth. So regular rinsing with this inhaler is really important after use. We usually tell people to use the albuterol inhaler prior to taking a steroid inhaler, because you bronchodilate with the albuterol inhaler, which allows the steroid medication to get even deeper down in the lung. Now, because it's a mist that you're inhaling, you can get coughing and bronchospasm and irritation after use. It's definitely possible. When we use oral steroids, we sometimes will taper them down. We'll reduce the doses gradually. We'll probably get into that in another module. And monitoring of growth and development in children, because as I said, steroids can, especially oral steroids, can inhibit or slow down growth. So there was that initial concern with these inhalers. The big one, monitor for yeast infections in the throat, rinse your mouth after every use, take the inhaler regularly, and always take your albuterol inhaler before the steroid inhaler. Okay, so cromolyn inhaler, remember it's a mast cell stabilizer. What are mast cells? Well, they're part of the immune system. They contain a lot of histamine. So when they get released as part of the allergic system, histamine causes bronchospasm and wheezing. So if we can stabilize the mast cells with cromolyn, which cromolyn inhaler, or a nidocromil inhaler, you may have seen that on one of the earlier slides, nidocromil. They're both the same group. You can use these for mild asthma. They're definitely not as effective as inhaled corticosteroid inhalers. We can sometimes use them in COPD. They also come as a nasal spray, so we can try and stabilize the mast cells from releasing their histamine in the nose for allergic rhinitis. And it also actually comes as an eye drop for allergic conjunctivitis. So spring or fall, bad allergies, red eyes, runny nose. You could use cromolyn eye drops, cromolyn nasal spray, and for asthma, you could use a cromolyn inhaler. I'm going to tell you, these are not very effective compared to the nasal cortisone sprays or the inhaled corticosteroids for the lungs. So the action we went over already. Adverse effects. You can definitely get coughing and hacking and throat irritation from cromolyn or nidocromil. So it's just the powder that's irritating the back of the throat and the lungs. Nursing responsibilities. They're really, because it's really not used very much anymore since the inhaled corticosteroids came out. Nebulizer treatment is the only form available now. So, I mean, know the name, know what it is, but also realize that it's been relegated to a much smaller use because of the inhaled corticosteroids. Okay, so the next drug is one called Montelukast, and it's actually a pill, and it was very popular when it came out 15 to 20 years ago. We thought it would be very effective. So it's a leukotriene receptor antagonist. Okay, so what does that mean? Well, leukotrienes are involved in the inflammatory cycle. So the feeling, well, if we can block leukotrienes, it's probably going to help inflammatory conditions such as asthma. Maybe try it in COPD. Try it for allergies, allergic rhinitis, allergic skin conditions. So it was tried for all kinds of things. But it never really became popular because it wasn't that effective. Okay, so the indications were for persistent asthma. But you can see on that table, that stepwise table, that it's usually at the bottom somewhere where, sure, you could try it, but it's just not that effective. And especially with inhaled corticosteroids, it's really fallen off the list, basically, for asthma or COPD. I think it's a good idea to know that it's a leukotriene receptor inhibitor, that it's used for asthma, that it could be used for allergic conditions of the nose or the eye, but also knowing that you're not going to see this much of it because it's just not that effective. Adverse effects in the spray, in the pill form. Sorry, it's in the pill form. It could cause a bit of irritation of the nose. I guess the big one here is there was a bit of evidence that it could cause some psychiatric issues and suicidal ideation. It's just not used that much, so it doesn't make the medical information as much anymore because it's infrequently used. Contraindications, well, hepatic failure because it's metabolized by the liver. Okay, so nursing responsibilities not for acute asthma attacks. Well, definitely that's the beta 2 agonist group, right? That's the albuterol group, and definitely not used as initiating therapy for asthma. Like no one would start on Montelukast when they come in and they're diagnosed with asthma. They're going to start on albuterol and likely an inhaled corticosteroid. Okay, so guess the takeaway message is, yes, it's a pill form. It's a leukotriene receptor inhibitor. Is used for allergic conditions, including asthma. Not overly effective. Okay, so the next drug, which has been around for a long time, is called theophylline. So look at the ending. It's basically one of the it's the main one in this group. It's a coffee. It's a caffeine derivative. It's very similar to caffeine. It comes intravenously, and if you were to go back in time 25, 30 years ago and you walked on the respiratory ward where people with COPD and asthma were admitted, everyone would be on theophylline intravenous drips. It was a very popular drug as a bronchodilator decades ago. It also comes in a pill form. It's rarely used now, mainly because it's not very effective, and it easily becomes toxic. So let's look at the indications. So yes, it has some bronchodilation effect. We can use it as a maintenance medication orally for asthma. But again, we have much better medications now with inhaled corticosteroids and long-acting beta agonists that we just don't use this drug very often. It could be added in some algorithm for status asthmaticus, which is basically a medical emergency where someone is having a severe asthma attack that is not responding to your typical treatment, such as albuterol and inhaled corticosteroids and IV steroids and epinephrine and IV magnesium. Okay, we could add theophylline to it. We probably still wouldn't, because we just don't use it very much. But you do seem to know, I think you still need to know a bit about it. And it's sometimes used in COPD. Again, going back in time. How does it work? There's some relaxation of the bronchial smooth muscle. And so it bronchodilates a bit. The problem is it has a very narrow therapeutic window, meaning the dose you need for it to be a bit effective is the dose that's approaching toxicity. So that's not a great drug when there's a narrow therapeutic window. Nausea and vomiting, well, if you can imagine, it's a stimulant, just like caffeine. So if you had 10 cups of coffee, do you think your stomach would be upset? Would you potentially feel like vomiting? Would you be irritable, tachycardic? It's all caffeine side effects. Contraindications, congestive heart failure, for sure. You're going to make the heart beat fast. If you already are at risk for arrhythmias, this can put the heart into all kinds of arrhythmias because it's a stimulant like caffeine. Coronary artery disease and angina or a previous myocardial infarction. Again, this is making the heart work very hard. It's making the heart tachycardic. We wouldn't use it with heart disease conditions. And the other problem with theophylline, and one of the reasons why we've really stopped using it, is it interacted with so many other drugs, including warfarin, which is used very commonly. So for all these reasons, theophylline, even though it's tested on still, it's not a popular drug any longer. Nursing responsibilities. So there's the level, because you can draw theophylline levels. But that's how toxic it is. That we need to draw blood levels to check on the serum level of theophylline. High risk for toxicity, signs and symptoms of tachycardia, anorexia, nausea and vomiting, restlessness, irritability, right? Then people were told not to have coffee because that adds to the theophylline effect. So know a bit about the drug. know that it's used for COPD and asthma in the past, know its side effects, but also realizing that the toxicity has made theophylline a bit of a drug of the past. Asthma action plan. So asthma is a fluctuating respiratory condition, just like COPD. People have COPD flare-ups where they get more shorter breath, increased phlegm and sputum production, and then they improve after treatment. So they're chronic conditions. So with asthma, you can be stabilized with medications, in particular inhaled corticosteroids, but you can get flare-ups, say after a cold or an upper respiratory tract. You get a flare-up if you're wheezing and your shortness of breath. Or it can just happen depending on which season we're in, that you get flare-ups of your asthma. So an asthma action plan is usually an agreement between a healthcare provider or an asthma clinic with the patient, since over the span of months to years, asthma medication and asthma treatment needs to be adjusted depending on your symptoms. So, for example, if you're asymptomatic, you're able to do all your activities and you're able to exercise normally, do strenuous physical activity, if that's what you're doing, then you would be in the green zone. You would have full asthma control. Okay? So there would be no reason to adjust your current treatment plan. If, for example, you find that you're having to use more of your rescue inhaler, your albuterol, or you're having difficulty doing your regular activities or exercises, or shortness of breath is interfering with your sleep, or you've acquired a cold and now you've been wheezing for weeks, or you're having to use, say, your rescue inhaler more than 3 or 4 times per week, which doesn't sound like a lot, but normally people are maintained just with their inhaled corticosteroid, for example. Or you're missing school or work because of your asthma. That would put you in the in what's called the yellow zone, which is loss of control. It's not severe, but you've lost control of your asthma. And that typically takes an adjustment of your medication. So the adjustment might be increasing the inhaled corticosteroids, maybe altering something in your environment, such as, say you got a new pet. Well, the pet may have to go. Or say you've taken up smoking, okay? There'll have to be a discussion about the harm of smoking and asthma. So whatever it is, and sometimes just the asthma flares up. So often medications have to be adjusted. And then finally, your symptoms can become severe. And by severe, excessive coughing and wheezing, tightness in the chest, shortness of breath, sweating, difficulty speaking, anxious with the shortness of breath, severely reduced level of activities because of the shortness of breath, and lack of benefit or relief with the rescue inhalers. And that usually means an immediate follow-up, whether with the healthcare provider, the asthma clinic, or the emergency room. So it really just depends on what zone you fall in, and that would be the red zone, by the way. So green, yellow, red zone, and there's a plan in each one of these zones of what to do. Okay, so you would typically either contact your healthcare provider, or you'd go to the emergency room to obtain emergent treatment. If you were in the red zone, for example, you might be given albuterol nebulizers. You may be given oral prednisone or IV prednisone, depending on how, or IV corticosteroids, depending on how severe the attack is. And often what's included in deciding what zone you're in is a simple peak flow meter, which is just a very simple meter that you can breathe into as quickly as hard as you can, and it gives you, on the side of the meter, it gives you a readout of the flow of air that you're able to breathe out, you're able to expire. And that number correlates with how poorly controlled your asthma is. So if you're able to breathe out very quickly and breathe out a lot of air in a short period of time, that's a very good indication that your asthma is well controlled. If when you check with your peak meter, your peak flow meter, you're not able to breathe out very much air, and it's very difficult and slow to get out the air, the number that you get will be low, and that'll be an indication that you need to do something, since you're in the yellow or the red zone. Okay, so that's basically an asthma action plan. Okay, so the next topic, we're changing gears here a bit. We're going to talk about allergic rhinitis. So allergic, we know what that means. Rhinitis, inflammation of the nose, and the common cold. So allergic rhinitis is really like an allergy anywhere else in the body. You have IgE antibodies that are released by white blood cells, and the IgE antibodies are attaching to mast cells, and mast cells are full of vasoactive and inflammatory chemicals. When the allergen, say for example this in this image it's pollen, but whatever allergen it is in the environment binds to the IgE on the mast cell, the mast cell releases histamine and many other inflammatory chemicals, which then act on the tissue of the nose and the blood vessels of the nose to cause mucus production, vasodilation of the capillaries that cause the capillaries to become very leaky in the nose, and you end up with a congested nose, sneezing, itchiness, irritation of the nose. So that's basically allergic rhinitis. And we'll talk about some medications to control this issue. Okay, so let's just talk generally about allergic rhinitis. How are we going to address someone who has either a runny nose, a congested nose, an itchy nose, stuffy, difficulty breathing at night, and they just want some relief? Okay, so it depends on what the underlying problem is. If it's an allergic issue, for example, this happens every spring or fall, and they're typically congested and sneezing and unable to sleep because their nose is blocked. Well, we're going to use medications that try to block the allergic system, and also medications that might shrink some of the nasal tissue so that it's easier to breathe. Okay, so addressing the allergic component and also addressing the swollen, irritated tissue in the nose. So just keep that in mind when we go through some of the medications. The first one here is diphenhydramine, very common drug. Brand name is Benadryl. So this is used all the time for allergic reactions. So whether you have an allergic rash or you have generalized itching, or you have it comes in eye drops for itchy allergic eyes. We can use it for motion sickness, and we can also use it for insomnia. Now in this case, we're going to be talking about allergic rhinitis, an allergic reaction in the nose. But why does it work for insomnia? Well, diphenhydramine has a lot of anticholinergic effects. So what does that mean? Anticholinergic effects. It means wherever there's acetylcholine, it's going to have some effects. And we know acetylcholine is the main neurotransmitter in the parasympathetic nervous system. So it's going to have parasympathetic side effects, or anti-parasympathetic side effects. But acetylcholine is an important neurotransmitter for staying alert within the brain. So when we give people anticholinergic drugs, we make them tired and fatigued. And that is always a concern with old people and anticholinergic drugs. So if you have an 80-year-old person that you want to start on a medication that has anticholinergic side effects, it's always a concern, and we often try to avoid it because it makes them tired and the potential for falling is very high. Okay? So let's look at the action of this drug. It's a histamine, it's an H1 blocker. So a histamine 1 receptor blocker. It stops histamine from getting onto the receptor at the tissue site and causing all the effects that histamine will do once it attaches to the receptor, such as increased mucus production in the nose, increased nasal congestion, vasodilation of the blood vessels in the nose. Okay? And remember, the second action is anticholinergic effects. So just think of some of them. If you're taking this medication orally, it's going to dilate your eyes a bit. It's going to give you a dry mouth. In old people, it could easily confuse them and make them tired. So just keep in mind anticholinergic side effects and repeat them 5 or 6 times so that finally they just stay in your mind. Oh, okay, anticholinergic side effects, it's these, it's all of these that I've just listed. So just so you remember it, okay? The odd thing about diphenhydramine, like a lot of things when you give medications to children, it can have the opposite effect. It can activate children. So paradoxical effect in children. You know, sometimes if you give a child a stimulant, it actually has the opposite effect. For example, caffeine in a child can have relaxing effects. Not that we give coffee to children very often, but in studies it's been shown that caffeine, we used to actually sometimes give it to patients that had ADHD as to help them concentrate and relax. Okay, so this drug, sedating in adults, can be stimulating in children. So if you give this to your child who's itching and they are running around wild, you might think, oh, this has a stimulating effect in this child. Okay, so but in general, drowsiness, dry mouth, maybe some dilated pupils, a bit of tachycardia, maybe a bit of constipation, a bit of difficulty urinating in an older man. Okay? Contraindications. Well, if you dilate the pupil, you could always bring on the potential for acute angle closure glaucoma. Okay? And contraindications, well, if you have an extremely dry mouth already, you wouldn't want to use this medication. Another contraindication is the use of an MAOI inhibitor, like an MAOI drug, which are antidepressants that we used to use, MAOI, monoamine oxidase inhibitors. And they had so many drug interactions. There were so many drugs to avoid and foods to avoid that newer drugs came out, such as the SSRIs and the SNRIs for depression. And now these are really rarely used unless someone has resistant depression. And someone who has resistant depression has to be fully aware when they're on these drugs of what they can eat, what they can't eat, and any drugs they have to be very careful with. So, diphenhydramine is one of many, many, many drugs that you can't combine with this group of medications. Okay, so nursing responsibilities, definitely CNS depression, especially in an old person. Someone who's in the emergency room, they're 85 years old. We're giving them diphenhydramine for diffuse itching. They're getting it IV. Or say they've had an allergic reaction to a transfusion of blood, and we're giving them a lot of diphenhydramine. And then we realize a couple hours later that, hey, this person's really tired. They're off balance now. It's likely the diphenhydramine that we've given them. Okay, avoiding with alcohol, since alcohol obviously has some sedative effects, and so does diphenhydramine. There's some mild photosensitivity effects with this drug. That wouldn't be a huge issue with this drug. Avoid in the elderly. There it is. And as mentioned before, there's H2 receptors, histamine 2 receptors in the gastrointestinal tract that we'll come to in a completely different module. We're talking about H1 receptors, so histamine 1 receptors, and they're involved in allergies compared to H2 receptors that are involved with acid production in the stomach. Okay, so let's discuss another antihistamine, fexofenadine, which is, the brand name is Allegra. Loratadine is Claritin. And I think those are the two most common in this group. Desloratadine is Aureus. If you know the ending, and I think if you know the first three, you're doing very well. Again, anti-allergy medication. They're antihistamine. They block the H1 receptor, and H1 receptors are heavily involved in allergic reactions and the inflammatory cycle. So if we can block the H1 receptor with an antihistamine, we can control allergic symptoms. The difference between this group is that they're second generation compared to diphenhydramine, which is a first generation. And the second generation antihistamines are far less sedating. They have much more difficulty crossing the blood-brain barrier and causing sedation in people. So this can be used again for allergic rhinitis, hay fever, urticaria, which is an itchy allergic rash, eczema, which is a dry, scaly, itchy rash that people have, often associated with asthma, by the way. So it's an H1 blocker, H1 histamine blocker. Okay, so adverse effects. It can still give you a bit of a dry mouth. It just doesn't cross the blood-brain barrier very much, so it's not going to give you the sedation. It can have a bit of anticholinergic side effects, just not much. So you can see that maybe a bit of a dry mouth, minimal side effects in general. Contraindications, if you had severe renal disease, since it's excreted by the kidneys. Now, if you were to go for allergy testing, where they put a whole series of allergens as little tiny injections on your back and see which ones you're allergic to, you would need to stop your antihistamines days prior to the skin allergy testing. Otherwise, the antihistamine will interfere and make the allergy testing inaccurate, since it may not show the allergic reaction. Any allergy type testing, we stop the antihistamines prior to the testing so that we know that the results are accurate. Again, avoiding with alcohol because it can still have a bit of anticholinergic and a bit of sedating, but not very much at all. So know the difference between a first generation antihistamine and a second generation antihistamine is really that the second generation is far less sedating. So it's far safer since it has much less anticholinergic side effects. Okay? And it's always better to take an antihistamine before you have the allergic symptoms, such as hay fever. So say every April or May, you know that you get red eyes, runny nose, stuffy, congested. It's always better to block the histamine receptor prior to the symptoms, because once the symptoms have started, it means that the histamine's already been able to activate the inflammatory cycle. So now you have to play catch up with antihistamines to start blocking the histamine receptor. Whereas if you block the histamine receptor right from the beginning, before any symptoms and before any histamine has been released, they are much more effective. So this next slide of someone's back is just showing you allergy testing, where they're showing you so different allergens are injected under the skin, subdermal or subcutaneous, and then a reaction develops in a very short period of time while you're there. And the degree of the reaction tells them how sensitive you are to that particular allergen. So you can sometimes have 20 to 30 of these on your back or more, and just each one is waiting for your body to see if it's sensitized to it. And you can have all kinds of allergens put in, allergens to dogs, to cats, to dust mites, to different types of trees, birch, maple, oak. It just goes on and on for all the different allergens that can be tested. Okay, so we're still on the topic of allergic rhinitis, and we spoke about the fact that you can control the allergic component with antihistamines. And now we're going to talk about controlling the inflammatory part with a nasal corticosteroid. Okay, so there's the allergic component of the histamine release and the histamine effects, which is vasodilation, leaky blood vessels, mucus production, sneezing, and antihistamines can be very effective for that, but the tissue is all boggy and swollen as well, and this is where a nasal steroid can be very effective. So fluticasone or Flonase is a very common one. There's another one called triamcinolone. They're both just steroids that have been put into a nasal spray. That one's called Nasacort. There's one called beclomethasone, which the brand name is Becanase. So they're all basically very similar. Okay, and the indication is for allergic rhinitis. That's the main treatment choice the best treatment to address allergic rhinitis. You can also use it for nasal polyps. So if you can imagine polyps, which are just enlarged, hypertrophied tissue that you can get, for example, in your colon, that would be colon polyps. You can get those in your nose, and they're often associated with asthma and eczema. So they're allergic in nature. And we often want to try and shrink them down so people can breathe much more easily. They block the nasal passages. So nasal steroids can shrink down nasal polyps. And sometimes we'll use these nasal sprays for sinusitis. So the exit for the sinuses are into the nose. So from the maxillary sinus, which is the one behind your cheek, the frontal sinus above your forehead, a lot of the sinuses drain into the nose. And when those little pores or openings, the meatus, are blocked because you have so much congestion, you can get sinusitis secondary to rhinitis. So if we use a nasal steroid to shrink the tissue in the nose, it can really help people with sinusitis. Okay, so very effective for all three of these conditions. What's the effect? Well, these are steroidal anti-inflammatory medications. Most of the side effects are really just local. Epistaxis, so it can irritate the blood, the steroid can irritate the blood vessels in the nose, and you can get a bleeding nose from it. If when you're spraying the inhaler into your nose, if you breathe hard enough, when you breathe through your nose to get the spray into your nose, if you breathe hard enough, it's going to go to the back of your nose and then into your lung, so you might get a bit of a cough. So maybe some practice in how you inhale and how you spray them into your nose is needed. You can get nasal ulcers because steroids can break down tissue, right? They can irritate tissue. They can thin the skin, so you can get ulcers within the nose, and just local irritation to the nasal tissue, the mucosa. Okay, so those are the main side effects. So contraindication masks an infection. I think I mentioned this before. That is much more common with systemic steroids. A nasal spray, a nasal steroid spray, it might mask a local infection in the nose. Most of the steroid in a nasal spray does not get absorbed into the bloodstream. But I think it's good to remember that in general, steroids are immunosuppressants, especially systemic steroids, and they can lead to infection because they've suppressed the immune system. Under nursing responsibilities, so phenylephrine we're going to talk about. That's a vasoconstrictor, so it can be a spray. You can also have, so it's often topical that you spray into your nose, and it shrinks the tissue by vasoconstricting. So it's an alpha-1 agonist. And by doing that, it really shrinks down the tissue quickly. So if you're using phenylephrine and a steroid spray at the beginning, you would use the phenylephrine first to shrink down the tissue, and then the steroid spray so that it can get in even further. Okay? And sometimes people have such terrible nasal congestion and difficulty breathing, they will start with an oral steroid to really shrink down the tissue, and then transition to a nasal spray if it happens to be allergic rhinitis, or to an inhaler, like a steroid inhaler, if it happens to be for asthma. Okay? So monitoring for growth rate in children. Again, I mentioned this was a concern years ago. With nasal cortisone sprays, it would be a pretty low concern in general. it would be more with systemic steroids. Okay, so pseudoephedrine or phenylephrine. Okay, so look at the middle part. Ephedrine, ephrin. So these are very similar to epinephrine. Okay, these are alpha. So there's sympathomimetics. So why do we take this either by mouth or as a nasal spray? Well, they're alpha-1 agonists. And when either take, well, so if you take this orally, it'll be an alpha-1 agonist all over your body, right? If you take it nasally as a spray, it'll tend to act locally within the blood vessels of the nose. So, what are the adverse effects of a sympathomimetic? Well, if you're taking a spray, an alpha-1 agonist spray, and you're spraying it into your nose, and you're vasoconstricting the blood vessels so that you can breathe better, what's going to happen if you continue to take it for more than 5 days, say, is that the blood vessels have been used to being constricted, will now vasodilate, and you'll get rebound nasal congestion. So that's one of the reasons why we really don't like people on these decongestants, whether they're oral or nasal decongestants, for a long period of time. Okay? And remember, so there's sympathomimetics. So they're going to cause insomnia, restlessness, anxiety, right? Just like any stimulant to the sympathetic system. Contraindications. So if you look at the packages for Sudafed, which is pseudoephedrine, or one of the nasal decongestant sprays like Otrivin, you're going to see that these nasal decongestants, or decongestants in general, for your nose and for stuffiness, they're going to say do not take if you have hypertension, because it's an alpha-1 agonist. It's going to raise your blood pressure. Coronary artery disease, which is also another way of saying angina, because it could worsen your angina, because it's going to make your heart beat faster, and it's going to put your blood pressure up. MAOI inhibitors. So if you take MAOI inhibitors, definitely these stimulants would be contraindicated. And also children in general, children less than 6 years, you don't want to be getting them used to nasal decongestants. And once they've used them for 5-7 days or longer, the nose is now used to having this vasoconstriction for the congestion, and it's very hard to now remove the spray because they get congested every time you stop it. So really not for children. Nursing responsibilities, definitely advising patients to limit the use of nasal decongestants, nasal stimulants like pseudoephedrine or phenylephrine to 3 to 5 days maximum. Telling patients to take the decongestant prior to the nasal steroid, for example, so that it shrinks the tissue first, and then you can deposit the nasal steroid deeper into the nasal cavity. So remember, these are short-term use decongestants. The nasal steroids you can be on for months and months and months, because they're not actively vasoconstricting the blood vessels. They're shrinking the tissue over time. Okay. Okay, so we're going to talk a bit about codeine, which is an opioid. And we're talking about codeine, or one that's very similar to it called hydrocodone. Not necessarily for their pain control, but for they suppress the cough reflex. Okay, so for years we've used codeine syrup and hydrocodone syrup to just try and help the cough reflex, especially for people that just can't get any sleep. Because we know opioid narcotics do suppress the cough reflex. So we also know that codeine can be used as a painkiller, as an analgesic, but we're not talking about that use here. So the indication under this section is really for a chronic non-productive cough, a cough that's keeping someone up and they have insomnia from it, and it's just making them feel miserable. So we'll often try hydrocodone or codeine. Where does it act? Well, there is a cough center in the nervous system, and it acts on the cough center to try and suppress the cough. It's also going to have all those opioid side effects. So sedation, opioids are sedating. Dizziness, because it acts on the brain, a lot of them can cause some dizziness. In high quantities, in large quantities, codeine, just like any other opioid, can cause respiratory depression. Another big side effect to an opioid or narcotic medications, constipation. Most people that get a narcotic should likely receive advice on avoiding constipation or advice on taking a laxative. Often people that leave hospital that require narcotics for pain, for example, leave with a prescription for a laxative. So they often go hand in hand. Contraindications, well, definitely someone who has respiratory depression for some other cause, like for example, we're giving them benzodiazepines, or they have some kind of head injury and they have respiratory depression. We're not giving them narcotics such as codeine. Alcoholics, alcohol can be a depressant, a respiratory depressant and a CNS depressant. So adding an opioid to someone who's abusing alcohol would be avoided. So taking as prescribed, avoiding driving initially until you know the effects of any depressant or any CNS depressant, such as a benzodiazepine, an opioid narcotic. So people that have received benzodiazepines or opioids at the emergency room can't just leave and get into a car. They need to call someone to pick them up, okay? Because we don't know the effects. Avoiding alcohol and other CNS depressant drugs, for sure. We used to use this particular opioid in children. Unfortunately, codeine, we now have stopped, well, not unfortunately, but we have stopped using codeine for the most part in children. And the reasoning is codeine is not the active drug. Codeine is converted to morphine in the liver, and morphine is the active drug. So what can happen is codeine syrup in children can be converted to morphine in varying degrees depending on the individual child. So some children with a certain dose of codeine weren't really breaking it down very much, so weren't having much analgesic effect to the codeine. Other children were completely breaking down the codeine and having a very large analgesic effect and respiratory depression effect. So because of this unpredictable breakdown of codeine, we don't use it in children very much any longer. Okay, so the next medication we're going to discuss is dextromethorphan. So this is marketed as a cough suppressant. And cough suppressants in general have limited effect. You can imagine that the cough reflex is a very powerful reflex to clear the lungs of either an infection or an irritation affecting the bronchial tubes or the alveoli. So it's a pretty strong reflex. So these have mild effects. And this drug is a distant variant, what's called a morphonian. So it has morphine-like effects, and it acts on the cough center in the brainstem, in the medulla. Okay, and it's often in many over-the-counter cough syrups that you'll see down the cold and congestion aisle at the pharmacy. So because of the group that it's in, it can have sedation, dizziness, and some CNS toxicity, and it has been abused in the past. And in some states and countries, dextromethorphan is behind the counter now. It's not a prescription medication, but it's behind the counter, so that large quantities cannot be purchased. So there's minimal contraindications. Hepatic impairment, if you had severe liver failure and you couldn't metabolize it, that would be one. And typically we don't give cough syrups to young children. We usually like to know why the child is coughing if it were to persist. I mean, if it's a simple cold with a runny nose, then that's one thing. But typically, younger children under the age of 6, we don't give decongestants or cough syrups to. So, as for any upper respiratory infection, in terms of nursing responsibilities, it's just a matter of educating the parents about the upper respiratory infection. Humidifying the room can make a very big difference in terms of coughing. Increasing fluid intake can loosen up the cough. After this medication, it's suggested not to take fluids for half an hour to an hour after, just to let it get absorbed properly. So guaifenesin, another ingredient you'll see in cough and cold remedies. Indications: mucus secretion, chest congestion with expectoration. This increases mucus secretion by supposedly increasing the cough. So if you have a cough with phlegm, and you want to try and increase the mucus expectoration, like getting rid of coughing out the phlegm, this medication could be used. And often, again, it's combined in all kinds of cough remedies. The contraindications, these aren't really contraindications as opposed to thinking about other things that the cough could be. You know, like a cough related to heart failure, a cough related to ACE inhibitors. There's children under 6 again, because we don't usually give expectorants to children. So this is in the group of expectorants. And category C for pregnancy, that's likely there because these medications just aren't that effective. So they're not going to rate very high on the pregnancy category. Nursing responsibility, so drinking lots of fluids with expectorants makes sense to loosen the secretions even more, to be able to spit out the secretions. Only take over-the-counter medications that treat the symptoms that the patient currently has. So if you were to walk down the over-the-counter aisle of cough remedies, there's there's cough suppressants, there's mucolytics that we'll talk about next. There's expectorants like this one that just loosens the phlegm. There's all kinds of mixtures. They're mixed with acetaminophen. Some are mixed with ibuprofen. So really a lot of mixtures. Most of them have not been shown to be highly effective. In fact, honey has been shown to be more effective than over-the-counter cough syrups such as dextromethorphan. So acetylcysteine. So this is a mucolytic, meaning it breaks up mucus. So it'll break up and digest the mucus. Unlike an expectorant such as guaifenesin, that supposedly just loosens the mucus off the bronchial wall. Now, the main indication for this drug it has nothing to do with this chapter. The main indication for acetylcysteine is for a acetaminophen overdose. So this is a highly effective antidote for acetaminophen toxicity to protect the liver from liver damage and liver failure from an acetaminophen overdose. The other thing that it can be used for is in patients with cystic fibrosis. You can nebulize or mist acetylcysteine in a mask into their lungs, and it can help break up that thick, viscous secretions since it acts as a mucolytic. Okay. And lastly, this medication has been shown that if you pre-dose someone before, say, a CAT scan that they're getting intravenous contrast for, this has some protective effects to the kidney from the IV contrast material. So as you know, IV contrast can be renal toxic. So pre-dosing acetylcysteine prior to CAT scans with contrast can be renal protective. Okay, so the actions, this will be more for this module, loosens thick viscous bronchial secretions, and then that will help someone, especially with cystic fibrosis, cough them up. Protects liver cells from toxic metabolites of acetaminophen overdose. Very true. This particular drug, if given in a timely manner, typically less than, well, the sooner the better, but less than 6 hours, is highly protective to protect against liver failure from acetaminophen overdose, which can definitely be deadly. Acetamin overdose can be extremely fatal and harmful because it's so toxic to the liver. So acetylcysteine is very protective to the liver. And the other action decreases radio contrast kidney injury, and we went over that already. So it can be given orally. We don't give it orally very often because it has an awful taste and smell to it. It smells like rotten eggs. So often for acetaminophen overdose, it's given IV. In cystic fibrosis, it's given as a nebulizer, as a mask to break up the secretions. And to protect against contrast prior to a CT, it's given IV as well. Responsibilities in terms of for this medication are basically minimal. Warning the patient about the taste and smell if you were to give it orally. It wouldn't be. We used to give it orally for Tylenol for acetaminophen overdose, but with acetamin overdose, one of the main symptoms of the toxicity is nausea and vomiting. So you can imagine trying to give oral acetylcysteine to someone who's already vomiting from the acetaminophen toxicity. So it's not very effective that way, so we use the IV route. Okay, so here's one of my favorite drugs in this module, honey. So especially in the cough, the cough suppressant part of it. So honey is definitely a natural cough suppressant and is effective at reducing coughs. And the darker the honey, the more effective it is in terms of its cough suppressant effect. So it can be more it's more effective than dextromethorphan. We don't use codeine as much anymore, especially in children, as a cough suppressant. Remember, codeine is metabolized to morphine in the body, and everybody has variable ways of metabolizing it. So one person may not break it down to morphine, and another person may break it down fully to morphine, so it's unpredictable a bit. So not used as much anymore.